Previously, in the CNS Pharmacology Masterclass, we talked about the antiepileptic drugs classification, and we mentioned that we have a first-generation antiepileptic drugs, which are also called the classic antiepileptics or the older antiepileptics. And we also have a second-generation antiepileptic drugs, which are also called the newer antiepileptics. And Levetiracetam is included in the second-generation antiepileptics. Other examples of the second generation include the vigabatrin, the lamotrigine, the topiramate, the gabapentin and pregabalin, and the tigabine. Examples of the first generation include the phenytoin, the carbamazepine, the valproic acid, the ethosuximide, the phenobarbital, and the benzodiazepines. So in our talk about the levetiracetam, we will start with an overview. So a famous trade name for this medication is Keppra, and this is how the packaging of Keppra looks like. And levetiracetam is a broad-spectrum antiepileptic drug, and it is one of the most commonly prescribed antiepileptics because it has less adverse effects compared to the others. And levetiracetam was first approved for medical use in 1999 in the United States for the treatment of epilepsy. Moving on to talk about the mechanism of action. So the levetiracetam binds to the SV2A protein and inhibits it. Now the SV2A is a synaptic vesicle membrane protein. Now the SV2A protein is available in the synapse that you can see in this picture here. It is what connects the nerve endings together. And the synapse contains a presynaptic vesicles. Those vesicles contain neurotransmitters of different types, and those vesicles will go to release those neurotransmitters by the process of exocytosis. And when those transmitters are released, then the action of conducting a signal occurs between the nerve endings. So the SV2A protein function is to help in the process of exocytosis of the excitatory neurotransmitters into the synapse. So the SV2A protein is available in the vesicle membranes. So in those vesicle membranes, right here, and right here, and around the vesicle membrane, and it is exactly available in the vesicle membrane of the excitatory neurotransmitters. And the function of this protein is to help the process of exocytosis to occur to these vesicles for the excitatory neurotransmitters to be released into the synapse. So it basically helps the vesicles pop. So this is SV2A helping the vesicles to pop and release the neurotransmitters. Now the levetiracetam inhibits this protein. It binds to the protein and inhibits this protein. So inhibiting the SV2A by the levetiracetam leads to less excitatory neurotransmitters released to the synapse. So when we inhibit this protein, there is less exocytosis occurring and less neurotransmitters are released into the synapse. Now, if you remember previously from the CNS Pharmacology Masterclass, we talked about on how to stop a seizure, and we mentioned that we either have to block the sodium channels or we have to enhance the GABA. The GABA is the inhibitory neurotransmitters. So when we enhance the GABA, we enhance the neuronal inhibition, or we have to block the excitatory neurotransmitters. And the levetiracetam works on the third option. It inhibits the release of the neurotransmitters, thus there is less neuronal excitation and ultimately stopping the seizures from occurring. Now let's talk about the therapeutic uses of the levetiracetam. So it has a broad spectrum antiepileptic activity, as we mentioned, and it can be used as monotherapy or as an add-on to treat seizures. And it is FDA approved for the focal seizures in adults and children, and in idiopathic generalized onset tonic-clonic seizures, and for myoclonic seizures of juvenile myoclonic epilepsy in adolescents older than 12 years of age. Now, the levetiracetam is also used off-label. Off-label means that it is not FDA approved, and off-label uses of the levetiracetam include the status epilepticus and for prophylaxis against seizures in subarachnoid hemorrhage and in traumatic brain injury and in palliative care. Now let's talk about the adverse effects of the levetiracetam. So it may lead to central nervous system side effects like ataxia. Ataxia is a disorder of coordination. The patient may have problems in coordinating legs movements, leading. The patient may have problems in coordinating lower limbs movements, leading to trouble in walking, or they would have problems coordinating their upper limb movements, or they would have problems coordinating eye movements or speech. Levetiracetam also lead to dizziness, and it may lead to lack of energy. Now, it also lead to leukopenia and eosinophilia, and it may rarely lead to pancytopenia, which are all blood-related side effects. The medication is less commonly may lead to behavioral and mood changes such as irritability, aggression, agitation, anger, psychosis, anxiety, depression, and emotional liability. And approximately 20 to 30% of patients complain of these symptoms. And it rarely leads to hypersensitivity reactions in form of a spreading rash, progressing to Stevens-Johnson syndrome, and toxic epidermal necrolysis. Now let's talk about the pharmacokinetics. So levetiracetam is available as oral and intravenous formulations. The oral formulation is rapidly absorbed from the gastrointestinal tract with 95% bioavailability, and the food slows the absorption but doesn't affect the amount absorbed. Regarding distribution, the drug is protein bound by 10%, and the rest is distributed to body tissues, including the brain, where it exerts its effects. And 30% of the drug is metabolized by enzymatic hydrolysis of acetamide group in the blood, and the liver has a minimal role in metabolism of this medication. Around 2% of this medication is metabolized by the liver, and the rest is either metabolized by the blood or excreted unchanged in the urine. And the plasma half-life of this medication is around 7 hours. Regarding dosing of this medication, so the intravenous dosing is the same as oral dosing because the bioavailability with the oral dosing is almost 100%, so that is why the intravenous dosing is the same as the oral dosing. And with this medication, there is no loading dose. And regarding dosing in adult patients, we start with 500 milligrams twice daily and titrate up until response occur. And titration is every 2 weeks by adding 250 to 500 milligrams to the total dose. And the max dose is 3000 milligrams per day. And dosing in pediatrics is that it is used in older than 5 years of age children, and we start with 20 milligrams per kilogram per day divided into 2 doses, and we titrate up by 20 milligrams per kilograms every 2 weeks. And the max dose is 60 milligrams per kilograms. Finally, regarding the drug interactions, so this medication has minimal drug interactions because it is not metabolized by the liver, it's metabolized by the blood. So that is why it has minimal drug interactions. And with that, we reach the end of this video. Thank you guys for watching. Please support this video by giving it a like and commenting your ideas and questions. And this video is a part of a bigger class. It's called the Central Nervous System Pharmacology Masterclass. You can check it out if you want.